Hello, everyone. I'm your host, Anish Bachu, and welcome to the fifth episode of KnowMD. With the global pandemic going on now, finding opportunities to shadow doctors and learn hands on about the various fields of medicine are extremely limited. So, in order to personally gain more exposure to these fields and to ensure that many others are also able to get this information, I have started this podcast where I will be interviewing doctors and medical professionals of various fields and professions so we can all learn together about these jobs. Today's guest is Dr. Somaiah Aroori, a consultant hepatobiliary and renal transplant surgeon. So, without further ado, let's get right into the interview. So, just for the sake of everyone, can you go ahead and introduce yourself and your profession again?
Okay, so my name is Somaiah Aroori. I'm a consultant surgeon at University Hospital Plymouth NHS Trust, Plymouth, England, UK. And I actually I'm mainly kind of three specialists, really. One is the main specialty is hepatobiliary and pancreatic surgery. Second specialism in general surgery, and third specialization is in renal transplant surgery. So the official title is hepatobiliary and renal transplant surgeon. That's my official title. And I became a consultant in March 2011, and I've been in this place since then.
Awesome. So, going back a little bit, where did you do your undergraduate degree and then your further degrees to specialize?
So I did my medical school in a place called Guntur Medical College in Andhra. So before the Andhra Pradesh was split into Telangana and Andhra Pradesh, it was the combined state. So I did my medical school from Guntur Medical College long time ago. Um, and then after the medicine MBBS, I went to All India Institute of Medical Sciences, New Delhi. I did my master's in general surgery. And then I came to UK in end of 1999. And since then, I've been in the UK.
And so, you finished your medical school all in India, and then
Yes.
did you also complete your residency and surgical training in India, or was that in the UK?
No, so after medicine, I did the 3 years of master's in general surgery. That is from AIMS, Delhi. So that's a postgraduate qualification. And then I wanted to do specialization in liver and pancreatic surgery, and also liver transplantation. So I came to UK to take my fellowship exam in end of 1999, and then I did my old style FRCS in 2000.
Mm-hmm.
And then I worked as a kind of, what we used to call a senior house officer for about 2 years. So from 2000 until 2002, I think almost July 2002, I did worked at kind of senior house officer level in surgery. Then I did 2 years of research in oncology from 2002 until 2004, and I got a degree called MD, Doctor in Medicine, from Queen's University Belfast. And this research was basically working on why some patients don't respond to chemotherapeutic drugs, especially in colon cancer. What are the reasons behind that? So I did 2 years of research on that. And actually, the drugs which I worked on are currently being used in the treatment of lots of cancers, especially gastrointestinal cancers. And then after 2 years of MD, then I got my number in surgical training, higher surgical training in the southwest of England. So we moved in August 2004 to southwest. I started my higher surgical training. So in the UK at that time, we used to call higher surgical training, and now they changed the name to specialty training. So a lot has changed since then, but at that time we used to call higher surgical. And then I did 6 years of higher surgical training in the southwest. So that is traveling to various parts, various hospitals in the southwest, from Plymouth up to Gloucester, which is the northernmost kind of hospital we used to travel. But we, after 1 year in Plymouth, we moved to Bristol. Then from Bristol, I was commuting to various places. And usually the postings can be either 6 months or 1 year. And I was lucky. Most of the places I did 1 year, so I had a kind of a bit of a stability. But that's what the surgical training does in the UK. Unlike, I think, US, once you start residency program in one hospital, that's where you complete it. But in the UK, we kind of rotate. So after my higher surgical training, then I went to Birmingham, Queen's Hospital, Queen Elizabeth Hospital in Birmingham, where I did my liver and pancreatic surgery training and also liver transplant training. And then I did 6 months fellowship in Cambridge, purely in transplantation. So that includes liver, kidney, pancreas, and small bowel transplantation. And then I got a consultant job in Plymouth, where I started as a registrar or a higher surgical trainee. And that's where I am now since March 2011. You're muted, Anish. Sorry.
Am I muted? Can you hear me?
Go ahead. Yeah, I can hear you now.
Okay. So that's very interesting. So what made you choose to specialize so far, and why specifically in like liver, kidney, transplant, and surgery?
So that's a very interesting question. And when I was in medical school, I wanted to become a cardiothoracic surgeon, cardiac surgeon, actually. So as a part of 3 years of general surgery training, we had to do cardiothoracic surgery as well. So I did 3 months of cardiothoracic surgery in AIMS. And at that time it was headed by Professor Venugopal, who is retired. And Professor Venugopal was the chief and head of the Department of Cardiothoracic Surgery. And he was the one who actually did the first heart transplant in India. So when I went to do the 3 months of cardiothoracic training, and I saw lots of people who are almost into their mid 40s, early 50s, they were still assisting. They were still not the chief, operating surgeon. They were all assistant surgeons or associate surgeons, and they were working under either Professor Venugopal or one of his, equivalent. But he was the chief. And I thought, I don't want to, get to the age of 45 and still assisting people, because I think that's how the system was set up in India. They're not allowed, or they don't allow surgeons to be independent until, they're of kind of certain, not caliber, I think, until you get that experience, or maybe until you satisfy the boss. That's how the system was in India. And I thought, no, I don't want to be like that. And then the boss I was working was basically gastrointestinal surgeon, and he was doing all sorts of gastrointestinal surgery from, stomach, liver, pancreas, rectum, including some thoracic surgery as well. So I got kind of fascinated and inspired by him, I must say. I was a very good surgeon, not necessarily the best, patient surgeon, but he was very inspiring, very supportive consultant. So then I thought, no, I want to become a gastrointestinal surgeon, or now what they call in India is a surgical gastroenterologist. But then there was no kind of training in liver and pancreatic surgery, even though we were doing ad hoc surgeries, but not liver transplantation. At that time, I think they didn't try at that time. We did 1 or 2 liver resections, but they were quite bloody operations. The mortality was very high, because the liver surgery was kind of upcoming specialty in India at that time. So I kind of decided that, no, I want to be a surgical gastroenterologist, but maybe specialization in either liver surgery or esophagogastric surgery. So I thought India was not offering that surgical specialty as a subspecialization. So, it was offering surgical gastroenterology, but the seats were very few. And in 1999, there were no MCH, that is the super specialization, qualification. There were no MCH in surgical gastroenterology at that year. I think every alternate year they had 1 seat. And I didn't want to waste 1 year waiting just to, for the next year to come up and then prepare for that MCH exam. So I thought, no, I'll come to UK, because I always had a dream of doing, getting the fellowship. I don't know why, but that was one of the dream. So then I did my PLAB exam and IEL test exam when I was still in my, final year of master's in surgery. And then I came to UK, and then the rest is history. Now, in terms of the why hepatobiliary and transplantation, I always wanted to be a hepatobiliary, and no, not always actually. Initially, I wanted to do esophagogastric surgery. So that's the surgery to do with the esophagus and stomach.
Yeah.
As a part of the higher surgical training, we have to do 2 years of colorectal surgery because most of the emergency surgeries we have to do in this country is something related to the colon and the rectum. So 2 years of colorectal surgery, and then 1 year of esophagogastric surgery, and 1 year of general surgery, and then 2 years in the chosen subspecialty. So by year 2, year 3, I could do most of the colorectal operations, and I didn't find that challenging. Then I did 1 year of esophagogastric surgery. Again, I didn't find that challenging or complex. And also, we had lots of anastomotic leaks. If you get a leak from the esophageal joint, it can be quite depressing, and patients can be in the hospital for months. Outcomes were not very good. So one, because of it wasn't challenging enough for me, and I could do the esophagogastrectomy pretty much most of the times, with minimal supervision. And I didn't find it challenging or complex. Then I thought, what, I think I need to try liver surgery, liver, pancreas, and transplantation. And that's when I decided. I was, I think, year 4 registrar. Then I thought, I need to go to a specialist unit like Birmingham or Cambridge. And luckily, I got 1 year in Birmingham, Queen Elizabeth Hospital, which is one of the biggest transplant unit in the UK, and maybe one of the largest in the world at that time, but not necessarily now. So then I did 1 year, and then I really enjoyed it. And it's quite a complex specialty, but it was very, very enjoyable, and satisfying. And it was fun. That's when I thought, no, that's what I wanted to do. But when I came to Plymouth, we were only doing renal transplantation here, not liver transplantation, which we are still trying to get the liver transplant unit. But because it's a small place and there are a lot of politics involved, because all the existing transplant units in the country, they basically, especially the big centers like King's or Birmingham, they're not very keen for another small unit to doing the liver transplantation. And then they said, well, there's a job coming up which includes hepatobiliary and renal transplantation. Would you be interested? So then I have to learn kidney transplantation within 3 months when I was in Cambridge. And that's it. So after that, I had the training in renal transplantation, job came up here, and they were very keen for me to come back. And then I took the consultant job.
I see. So what exactly is a consultant, and how do they differ from just like a normal surgeon, or is that just like the name for a normal surgeon?
No. So in the UK, the surgical training, obviously things have changed in last 10 years compared to when I started. So the system, how it works in the UK is that you finish your medical school. Okay, that is you call in India MBBS. I don't know what they call it in US, but in UK we call it MBBCH. In India it's called MBBS. In some Middle Eastern countries and African countries, they get an MD rather than MBBS. So once you finish your medical school, then you have to do 2 years of what we call a foundation year training. It used to be only 1 year, but then the UK has increased to 2 years. So FY1 and FY2, foundation year 1 and foundation year 2. Then you decide whether you want to go into a surgical specialty or a medical specialty. Okay. Of course, there are lots of different, again, subspecialties in both medicine and surgery, but broadly, medicine, surgery, psychiatry. So there are like, several kind of specializations you can think of. So you have to then do a core medical or core surgical training. So if you want to be a surgeon, you'll do 2 years of core surgical training, which can be a rotation between a general surgery or a colorectal surgery or a hepatobiliary or a urology, which is to deal with the kidneys. And then after 2 years, so during that 2 years, you will decide actually whether you want to become a general surgeon or whether you want to become a plastic surgeon or whether you want to become an ENT surgeon. There are different, obviously, various subspecialties. And then you go into higher surgical training, so which is basically 5 years. And after that, most of the trainees will do 2 years fellowship or 1 year fellowship at least. If they haven't done research, then they'll probably do a MD like what I did in Belfast, or a PhD, and depending upon how motivated you are, how much research you want to do, and whether you want to become an academic surgeon with
Yeah,
major interest in research. And then once you finish your higher surgical training, including the fellowship, then you'll become the consultant. So the consultant is like almost like the epitome. Once
yes,
you become the consultant, that's it. You are in charge of basically patients. Patients will be under your name. If you see them and if you operate on them, you have the ultimate responsibility for the patient. You will have juniors under you. You'll be training people. So it is basically buck stops, so we call it.
right.
If there is a problem, they'll come to you, and that's why it's called consultant surgeon. So of course, then the consultant surgeons can become managers. They can get into research if they want to. But ultimately, your title will be consultant surgeon, and you will have basically independent rights to operate on patients, see patients independently without any supervision.
I see. So it's like the highest level of surgery.
Yes. Yeah. Yeah.
I see. That's a lot. That's many years of training to get to that.
Absolutely. You see, that's the thing, isn't it? If you compare to the systems like India, where
Mhm.
after medical school, then you have 3 years of postgraduate degree, maybe another 2 years of super specialization, then ultimately then you become start with assistant professor, associate professor. So
Mhm.
there's, I mean, even in India, there's a lot of hierarchy, but the time they take compared to UK system is much
Much more.
shorter. I mean, UK, even if I let's say, for example, I came straight after medical school, and I didn't do my MS, still. So let's say 96 I finished my medical school, 99 I finished my MS. So let's take out the MS 3 years. So 96 to 2011, that is basically 16 years. And if you take out 3 years of MS, still took 13 years to get to where I was in 2011. And
Mhm.
that's why you can kind of confidently go to a consultant in this country and get treated,
Yeah,
because you know that they would have had all the right experience, and not necessarily the best surgeons, but they would have had all the training and the experience to deal with patients.
right. So I know you mentioned some oncological research that you did along
Yeah.
the way. Was that like the primary research that you did, or did you have any other research experience or experiments that?
So during my master's in surgery in India, we have to do research as well. So I had a research background, and interestingly, I my research in Delhi was also something to do with the cancers. So I gave actually chemotherapy to patients with the diagnosis of esophageal cancer as a part of my MS, and then I published that in Indian Journal of Cancer. So that was the kind of beginning in terms of the research experience. Then obviously 2 years of research experience in oncology in Belfast before I moved to England. So that is the kind of almost 5 years of experience I had. But Indian experience was mostly clinical experience, and research experience was like a part-time. But the 2 years of MD in Belfast was purely research, except some general surgery on-calls, one in 6 or 8, I think. I don't remember exactly, as a registrar. But daytime, we didn't have any elective commitments. We didn't have to go and see the patients. We didn't have to go and operate on any patients. Purely spending time in the lab, doing all sorts of things. The PCR, which you talk about for the COVID, for example, working on PCR, working on extraction of the DNA, RNA, Western blotting, all sorts of things for 2 years. Well, that was intense actually, but it was very fruitful. The chemotherapeutic drugs I worked on, for example, what we call a 5-fluorouracil, irinotecan, oxaliplatin, and what's the other drug? Irinotecan, yeah, yeah. Those are the three drugs I worked on. Are the drugs which are basically now used for the treatment of lots of cancers. So
Mhm.
I have a very good understanding of those drugs. And because I am a cancer surgeon, essentially I treat with hepatic liver, pancreas, and duodenal cancers. And the chemotherapy drugs used for those cancers are actually exactly the same thing. Not necessarily all of them together, but sometimes all of them together can be also be given. So I have a very good understanding of all these drugs, the side effects, and why some people don't respond to these chemotherapeutic drugs and so, because that was my research. And sometimes I feel actually I probably know more than the oncologist, as a surgeon, because of that background research.
Mm-hmm. So, in all that time that you were like still learning and like going through the school process and everything, did you have any other like jobs in between, or was it just like the 16 years of school and then like your first job?
So what happens, Anish, is that obviously during the medical school you don't get paid.
Right.
Okay. So in India, MBBS, you don't get paid. You have to rely either on your parents or scholarship, or you have to work part-time. But the problem is it was very intense. You go to the hospital or medical school at 8 o'clock in the morning and you used to come home 5:30, 6 o'clock in the evening. Then
Mhm.
you have to either eat it in the mess or you cook yourself. And I didn't really used to like the mess food in India. So I had to cook myself, and I had to study because
Yeah.
my background is quite interesting background, should I say, in the sense that my parents were basically uneducated. My mom and dad, they can't read and write, and both of them. My dad is a farmer, so I had a lot of issues financially. So I couldn't get the money from my parents, and I did get scholarship, but scholarship never used to come on time. So let's say, for example, monthly we used to get, I think, about 400 rupees, but that never used to come on time. So either after 4 months, 5 months, or 6 months. So that means for that kind of time period, I didn't have any money. So I have to borrow from somebody, or you borrow from the shop fellow who used to basically, lend the rice and vegetables and that kind of stuff. So that's how I managed. But I didn't do any part-time job during my medical school because my focus was always on getting the marks and topping the exams. So
Yeah.
I didn't do. But when I finished my medical school, when I was in the house surgeoncy, which is equivalent to foundation year 1 in this country, I I struggled quite a lot with money because the government was not giving the salaries on a monthly basis at that time. And so this was, I think, at that time, NTR government was there. I don't know, you heard about NTR,
Yeah.
Chandrababu Naidu's, father-in-law. And so the government was basically, they didn't have the money. They didn't pay us almost for 6 months during the house surgency. And my brother was with me, and he wanted to take long-term coaching for medicine. So I had to support him. I had to support myself, and there was no scholarship because the medical school is finished. So I
Mm.
didn't get the scholarship either. So at that time, then I was working in a nursing home. So after as soon as I finished my house surgency around 4 o'clock, 5 o'clock, 6 o'clock, I used to go and work in the nursing home until 9, 10 o'clock sometime, actually,
Wow.
both weekdays and weekends. So that's how I could kind of sustain myself. But there were no other, jobs during the actual medical school. But then once you finish your medical school, when you join the general surgical residency program in AIMS, we were getting paid. And honestly, we were really getting paid like almost like an assistant professor. So if you're assistant professor in any of the peripheral medical schools like Usmania Medical College, or because it's AIMS is a central government institute, we were getting really paid well, very well, almost 11,000 rupees at that time per month. But unfortunately, we didn't have time to spend that money, and the money used to go into the bank because we used to go almost at 7 o'clock in the morning to work. So we used to get up around. I mean, I was always an early kind of riser, really. So I used to get up 5 o'clock, 4:30, 5 o'clock in the morning, and study until 6:30. Then got fresh, and then go to the hospital at 7. And
Mhm.
then we used to come home around 9:30, 10 o'clock, pretty much almost on a daily basis. That's how we used to come. Okay. And AIMS is a very, very busy place. And there was time where almost all of the hospitals in Delhi were on strike because all of them are on the government hospitals and they can strike. But AIMS, because it's an autonomous body and completely an independently run hospital, and we couldn't go on strike. So literally me and one of my juniors, Mainak Deb, I still remember his name, and so we did 1 in 2 on calls. So literally every second day I was on call or he was on call. So if
Oh,
you're on call, you go at 7 o'clock in the morning, you stay in the hospital all day and all night. And
Yeah.
the next day night, we used to come home around 9:30, 10 o'clock. And imagine, we used to get exhausted. And then by the time you come to the hostel at 9, 10 o'clock, most of the messes used to be closed.
Oh, yeah.
And there was only one, place, the North Indian restaurant or hostel. And I never used to like the North Indian food because being a South Indian, used to
Yeah.
eating rice and curries and stuff. Oh, it was nightmare. And I was so thin and slim at that time, literally. Of course, I'm still the same, but I did put on weight and then lost weight. Just to say that during MS, we were paid. So we had money in the bank, but didn't have time to spend it.
Right.
So and then we were we always get paid for the rest of the years, really. So throughout the training, we got paid, so we didn't never need to worry about the money, really. We were getting paid really nice, really well in the UK.
Okay, cool. That's interesting. I didn't know at what point it switches, because I know how it works in the US is you have your undergraduate degree, and then you go to medical school and you get your MD. And then afterwards there's like your residency program. And once you're in residency to like specialize further in whatever
Yeah.
field you choose, at that point that's when you start getting paid.
Yeah, it's pretty much the same here. As soon as you
Yeah.
finish your medical school, you start your house surgency or
Right.
foundation, and then you start getting paid.
Right. Yeah.
Yeah.
Interesting.
Yeah, US system. I'm quite aware of US system as well, because I did at some point I did think of going to US, and I got fellowships as well after I finished the surgical training in the UK. But at the end, I decided not to go because I already kind of spent a lot of time in the UK, and then I had 2 kids, so we didn't want to just relocate to US, really.
Yeah. So moving back to like what your actual job, like what you do now. So as a consultant surgeon, I know I've talked to a orthopedic doctor, or sorry, an anesthesiologist, who's like the chief anesthesiologist at like the hospital. So I know much of what he does isn't actually like anesthesiology. Like he doesn't actually administer anesthesia as much. So is that the
Okay.
same case with you as a consultant, or do you do the actual surgery too?
Yeah, no. So we are pretty much hands-on. I really enjoy operating. I operate, but off late, for last I think 2 years, I got quite busy in research as well. So I'm running, a couple of national projects in the UK, and then one international trial called RAW study, RAW, recurrence after Whipple study, which is a multi-center study. We have about, I think, 40 hospitals across the globe which are taking part in the trial. We are in the process of submitting 2 grant applications for major funding from NIHR, which is the national funding body for research.
Mhm.
I was into management as well, but I gave up the management because I always wanted to do research as a part of my career. So because of the research interests, I kind of stopped the management activity. But I'm still pretty much hands-on. I operate almost 2 days in a week, sometimes 3 days in a week, sometimes it can be even 3.5, 4 days a week as well. So it's not completely kind of fixed, but definitely we do 1 day a week of operating,
Mhm.
1 or 2 clinics where we see the patients. And then we attend lots of multidisciplinary meetings where we discuss all the complex cancer patients with liver, pancreas, and bile duct and duodenal cancers. And then I also do kidney transplants when I'm on call, if there's a cadaveric kidney. But we also do a planned live kidney transplant. So obviously somebody wants to donate to their relatives, then I can, sometimes I take the kidney out, sometimes I put it in. So there are 2 surgeons operating. One will be taking the kidney out in the morning, and one of us will be putting it in. So either sometimes I take the kidney out and sometimes I put it in. I also do, other things like removing large kidney tumors when there is involvement of the big vein called inferior vena cava. So
Mhm.
a urologist, I usually do the kidney operations, but if the inferior vena cava is involved, they don't have the expertise in mobilizing the liver and clamping the cava. So I go and help them out as well. Sometimes I help the gynae oncologist taking out the lymph nodes close to the aorta. So basically, I do pretty much really the most complicated and complex retroperitoneal operations on top of liver, pancreas, duodenum, and renal transplantation. So lots of hands-on. That's why I really enjoy it, actually. I also run lots of training courses for the juniors. For example, last week I did a course for 5 senior trainees, and I trained them in using the intraoperative ultrasound scan to detect bile duct stones. I also run a cadaveric major liver resection course where they get to do, remove off of the liver from cadavers. I do lots of laparoscopic liver and pancreatic surgery as well, and I think probably I'm maybe one of the only one surgeon who does everything laparoscopically in place where I work. What else? I do lots of things, Anish.
Yeah, it does sound like it.
Yeah.
More generally, what are your hours kind of like for your job? Like, are they standard? Do they change a lot?
So what we do is we are 5 consultants. So we work as a team, and we have the kind of annualized job plan in the sense that there are no fixed commitments, but all of us have to provide certain number of clinics, certain number of operating sessions, certain number of MDT discussions, MDT meetings. Okay. So between 5 of us, we obviously share it over a period of 12 months. Obviously, we need to take out the annual leave, the study leave, all those things. Okay. So it's kind of fixed and not fixed as well, you can say.
Interesting. So, in like a typical week, how many hours are you in the clinic versus how many are you, or like how many hours are you operating versus just like in the office, and like how many are research related?
So research, unfortunately, I'm doing it in my own free time. I'm
Okay.
not getting paid. Okay. But when I have, let's say, for example, Friday afternoon, I didn't have any clinical commitments, neither the clinic nor operating, and
Mhm.
that's my time, and I could come home and relax and enjoy at home. But because of my major interest in research, I have to find time. So that's when I find time. When I'm free from clinical activities, I use that time to do the research work. But otherwise, operating wise, I said pretty much once every week we have operating, which starts around, we go to the hospital around 8 in the morning, and then we see the patient, consent them for surgery. And then we usually start the surgery around 10 o'clock because these are complex patients. So anesthetist will take about an hour to 1.5 hours to anesthetize them, putting the central lines, arterial lines, all sorts of things to
Mhm.
make sure that they're ready for the complex, surgery.
Right.
And then sometimes I finish by 5:30. If it's really, really complex, it could run up to, 7, 8 o'clock. But on average, we start at 8 o'clock in the morning and finish around 5:30, 6 o'clock when it's operating day. I do 1 or 2 clinics, which basically starts either 9 o'clock in the morning, finish around 1, or starts at 2, finish around 6 o'clock. Okay. And then we have a meeting on Friday, every Friday morning from 9:30 until 12:30, where we discuss all the complex patients.
I see.
And then we also join with other hospitals because we are a tertiary center. We are the one of the centers for all the complex liver and pancreatic cancer surgery. So we get referrals from 4 hospitals, and then we join in a video link meeting with them every Tuesday and Thursday. So these are the kind of clinical commitments. And then the rest of the time, if I am not on call, so when I'm on call, that means I can be on call for basically 4 days or sometimes a week at a stretch, from Monday to the following Monday. And when I'm on call, then any emergency that comes that week, either related to the liver, pancreas, transplantation, or general surgery, I need to take care of them. But obviously, I'll have juniors to deal with them first, and if they need surgery then or any advice, then they'll give me a call.
Right.
So either I go them, or I go to the hospital, or I give advice over the phone.
I see. And so the research that you're working on now, like in your free time, is that more related to your like oncological research that you did previously, or is it related to like the surgery?
So yes, the main project, which is the international study we're looking at, is pretty much related to pancreatic cancer. Not pretty much, it is related to pancreatic cancer. And yeah, that's oncological research. But obviously, there is a surgical slant to it as well. We are looking at the surgical factors as well.
Right.
Then the 2 other studies, one is again related to surgery, but not oncology. It's related to stone disease because, as I said, I'm a liver, pancreatic, and bile duct surgeon and gallbladder surgeon. So I do deal with the gallstones and stones in the bile duct. So that is something to do with the bile duct stones. We actually completed a retrospective study. We are doing a prospective study now. And then the third project was looking at the gallbladder cancers as well. So that's again something related to oncology. But the studies which we are planning to do, one is again, it's going to be an oncology surgery related to liver cancers. And the second one is gallstones related. So I have a kind of a theme, pretty much there are two projects. One will be looking at mainly the gallstones, and the second one is either pancreatic cancer or liver cancer research.
Interesting. So in like a typical week, how many surgeries do you do, or like how many does like your group of like 5 consultants like handle in a week? And like
So we do about five, anywhere between 4 to 5 major operations, either liver or pancreas operation. Okay. So if I have an operating list where I have to do a major case, either liver or pancreas, if it's a pancreas, there's only one case all day. Maybe a small case like gallstones operation, but if it's a major pancreatic resection, that will take pretty much all day. If it's a liver, if it's a small liver resection, that will take about 2-3 hours. And then the rest of the time will be filled by the small cases like a gallbladder operation or a bile duct operation or a hernia operation. Okay. But on average, between 5 of us, we do about 4 to 5 major liver or pancreatic resections. If there are no major cases to do like liver or pancreatic resection, then what I do is maybe 4 or 5 gallbladder operations, so removal of the gallbladders for stones or incisional hernias. I also do adrenal surgery, so adrenal tumors, and also what we call pheochromocytomas, which basically secrete high levels of noradrenaline, and that can push up your blood pressure. So if I have space on my list, once in a while, I do them as well. So I've got a lot of variety of things to do really, and I think it's a bit of an exception because these days you don't see specialties surgeon doing so many things. Either they'll have 1 or 2 specialties max, or they stick with the general surgery where they get to do all sorts of things, but not specializes in one particular thing. So I'm kind of other way around. I'm a general surgeon, but I mainly do liver pancreatic surgery plus the transplantation as well.
So yeah, on that transplantation, so you mentioned that you're a renal transplant surgeon. So you like what's that
Kidney.
process kind of like in like terms of surgery? Like how long does it take? Where do the kidneys you're using like come from?
Yeah.
And what's that process like?
So in the UK, the transplantation is mainly from people who have died, and they obviously express interest to donate their organs. But saying that now, you have to tell the government if you don't want to donate your kidney or liver or pancreas. So things have changed. So most of the transplants, kidney transplants we do are cadaveric kidneys. So somebody obviously wanted to donate. And then there are 9 retrieval teams. So these teams are basically a group of people. They'll have a surgeon, they'll have a nurse, and they'll have a person to carry the organs. So they'll go to the different places where there are donors who are waiting to be basically to die. And then either, they do it as a planned operation. So for example, we know that somebody is brain dead, and obviously the anesthetists or intensivists talk to the relatives. They're happy for the organs to be removed, and then the teams are mobilized from different places, and then they'll come into the hospital and they do it as a planned operation. Okay. And then once they're ready to take the organs, they'll switch off the ventilator and stop everything, and then obviously the patient will die and they will take the organs. So then they will match those organs. In this case, kidney, for example, they'll match this. So there is a national waiting list. So everybody in the UK who are on the waiting list, each hospital have their own waiting list. For example, in the Southwest Plymouth, we are at Renal Transplant Unit. So we know we have about, I think, 90 to 100 patients on our waiting list. Okay. So the kidney, for example, if somebody taken the kidney out in Edinburgh, and if that kidney is matched to one of our patients, then the kidney gets transported to our place. And we will know, the transplant coordinators will tell us that yes, there is a kidney which is matched to our patient. The kidney will be coming at such and such time. So the kidney, obviously, as soon as it's taken out, it will put on the ice and then transported to our place. And then we will go and see the person who is going to receive that kidney, consent them, and make them ready for the operating theater. And then we go into the operating theater, and then we obviously open the patient under anesthetic, and then we'll implant the kidney which came from Edinburgh or whatever the place it comes from. Now, on average, a kidney transplant takes, in terms of the surgical time, so from the minute we cut the skin until we close the skin, it can take between 2 to 3 hours. Mm-hmm. But that is kind of an average or median, should I say. But it is variable. If somebody, for example, 2 weeks ago, I did a transplant on a patient who had two previous transplants. And unfortunately, both of them failed. He had one on the left side, one on the right side. He also lost his native right kidney. So it was quite complex. So we have to put it inside the abdomen rather than in the retroperitoneum. And that took, I think, nearly 4 hours because of the previous transplant and everything. So it's variable, but a straightforward kidney transplant, I can finish it in 2 hours. So that's the cadaveric transplant side of things. If it's a live, say, for example, again, 2 weeks ago, I did a transplant on a patient whose daughter decided to donate the kidney to her mother. So this, we'll do it as a planned operation. That means we give them an operating date, then they come in the morning, seen by the anesthetist, and then they'll take into the theater. So first we take the person who wants to donate the kidney to the operating theater, and anesthetic, and I do this laparoscopically again. So we take out either right or left kidney, depending upon the number of blood vessels that each kidney has got, the anatomy and everything. Once we take the kidney out, the kidney will be flushed with a special solution called Marshall's solution, which is basically reduces the metabolic activity because it is cold. 2, it causes the cell arrest because it has got a high amount of potassium inside, and the high levels of potassium can make the cell to arrest. And then we will bring the person who needs the transplantation, okay? And then again, under anesthetic, we'll open the patient and then expose the blood vessels onto which we're going to plumb this kidney in, and then we implant the kidney. And that's it. Kidney usually works straight away. It'll start passing urine. It's amazing, really, to see the kidney that comes out, which gone onto ice. It's almost like, oh gosh, what happened to the kidney now? It's and then as soon as you connect it to the blood vessels, it starts working again. Okay, so that's the process when it comes to the live, either unrelated or related. But most of the transplants in the country, in this UK, are actually cadaveric, whether it is the liver, or kidney, or obviously pancreas has to be cadaveric. You can't take pancreas from a live person, but you can take half of the liver. You can take one of the kidneys from a live person.
So you mentioned how. Oh, sorry. Go ahead.
Yeah, go ahead, Anish.
So you mentioned how some of those are like planned ones, like they have a set date, like they planned beforehand and everything.
Yeah.
But how many, like, what's the comparison of like how many are like urgent surgeries that are like kind of like the ER, like you have to do it immediately, and how many of the ones that you do are like pre-planned?
So okay, that's a good question. In terms of the kidney transplants, because there is an alternative option to treat patients with kidney failure, you never do a kidney transplant as an urgent operation. Okay. Either it is a planned operation if somebody wants to donate their kidney, or unplanned. But when I say unplanned, it's not a life-saving emergency operation. Patients go on the waiting list. When there is a suitable kidney comes, then they get notification. And they usually get about 6-7 hours of notice. Okay. And then they come into the hospital, then we prepare them and transplant. But never, ever an urgent kidney transplantation because of the dialysis machine. You can put them on the dialysis and then it will take over the kidney function. Okay. But when it comes to the liver, for example, again, majority of the liver transplants are on the waiting list and as a kind of a semi-planned operation. Very rarely they have to do a transplant if the liver is failing, because there is no machine like dialysis machine, which can replace the liver function. Not yet anyway, not as effective as the dialysis machine. You can buy some time by filtering, and there is a special machine which can again take over the liver function, but only very, very short period of time, not for long term. So let's say, for example, if somebody had hepatitis infection, hepatitis can cause liver failure, okay? And if you don't get the liver transplantation done, then they can die. So those kind of cases, then you need an urgent liver transplantation, and then they go on the urgent waiting list. And then the first liver that is available from a donor, cadaveric donor, goes to that patient.
I see. And for your other surgeries, or any of those emergency ones, or are they primarily pre-planned?
No. So yes, there are lots of emergency surgeries. For example, if you have a stab or a gunshot to the liver, or a road traffic accident and liver is ruptured and is bleeding, then we have to operate on an emergency basis. Or if they had a perforated gallbladder with tummy full of bile, again you have to operate on them urgently. A small bowel obstruction, for example, or if it's a general surgery on call I'm doing, if they've come in with appendicitis, which is perforated, or a perforated bowel. So yes, I do, when I am on call for general surgery, and then I do operate on patients kind of as an emergency or urgent operations. When I'm on call for transplantation, then if the kidney becomes available, then I put do the transplant operations. But as an elective, it's mostly, planned operating, really.
I see. That makes sense. Can you think of any specific skills or attributes of a person that would be like particularly important for your line of work?
Oh gosh, yes, there are a few things actually you need to have. One is, as I said, I would say for a surgeon, especially the kind of specialty I'm in, not necessarily my specialty, but any specialty really. For a surgeon, I think there are a few things I would say it's kind of a must. One is, first thing is, you need to be a good doctor. Okay, how do you define a good doctor? You have to be good at your work. You have to have the knowledge. Okay, so you have to be knowledgeable. Two, you have to have that empathy. Because lots of patients I see have got cancers. Some of the pancreatic cancer patients, they've got basically literally 3 to 6 months to live. And if you don't have the empathy in terms of how to break the bad news, how to deal with the complex situations where the patients are emotionally kind of not right, with a new diagnosis, they have 6 months to live, their life is upside down. So we have to deal with them in a very, very sensitive way. Okay, because for them it's a life-changing event, even though that is my profession and I'm used to dealing with that, but still there were so many times where I actually literally cried with the patients. Okay, so you have to have that kind of empathy. The third thing is observation, because we learn a lot of things in surgery just purely observing others, observing the masters, observing our seniors, how they do it, how they hold a needle holder, how they hold the forceps, for example, how they take a stitch, how to deal with the tissues. So all that kind of stuff you learn from simply observing others. And of course, you have to practice as well. Okay, so that's why I say a surgeon should have an eagle eyes. Not just surgeons, I think any doctor, for example, because sometimes we can tell the diagnosis when actually patient is walking through the door, the way they walk, the way they look. Okay, we can tell what's wrong with the patients. Okay, and that comes with purely your observation skills, really. And then we have to be very strong, a lion-hearted, should I say, because liver surgery can be very challenging. And I'll tell you a story. This was about 4 or 5 years ago, and this guy comes in with a huge tumor, almost 3.5 kilos tumor. Okay, and I don't know how it got to that stage and how actually he didn't notice that there was something wrong with his tummy. Okay, and he lost a lot of weight. He couldn't eat because this tumor was pressing on the stomach. Anyway, so it was 3.5 kilograms, but it was still luckily operable. But imagine 3.5 kilograms of tumor inside the tummy. You don't have much space really to work.
Yeah.
So So I was operating. I was the consultant in charge that day, and then we started dividing the liver. Okay, after we taken the blood flow to the liver, the half of the liver which was going to be removed, and then we got into bleeding from two big veins, and we've lost 14 liters of blood on that day. Okay, normally you have about only 4 to 5 liters of blood, but he had 3 cardiac arrests on the operating table because of the bleeding, massive bleeding from the inferior vena cava and also from the liver veins. And he had 3 cardiac arrests. And imagine, to manage somebody who could literally die in front of you because of the bleeding, you have to keep your nerves really cool, and you need to manage that bleeding, stop the bleeding, but at the same time, you need to manage your team. You have to communicate with your anesthetist. Anesthetist says, okay, stop, Somaiah, don't do anything now. Let me catch up. Let me give the blood and the fluids to this patient. Let me bring his blood pressure up. Then you can have a look where it is bleeding from and then stop the bleeding. Okay. Mm-hmm. So you need to have that skill, that work kind of team working skill. You have to work with all the members of the team. It's not a one man or a one woman's job, I'm afraid. Mm-hmm. You know, it doesn't matter how skilled you are. If the anesthetist is not very good at it, if the anesthetist is not giving the fluid, not giving the blood while you're operating and losing the blood, you're not going to, keep the patient alive. Okay. So that another attribute, which is basically working with the other members of the team, knowing what skills they have, okay, what things they can do, which you can't do, okay, and respecting their strengths and weaknesses is really an important attribute for a surgeon, not only just a surgeon, for a doctor, but more so for a surgeon, because we call operating theaters. Why it is called operating theater? Why is it called theater? Because we put up a show. We are operating on patients, and everybody is kind of watching when we operate. Okay, and that's why it's called theater. It's theatrical. Mm-hmm. So I have to manage my team. For a doctor who is a physician, he or she have literally patients. They can prescribe medicine, and the patient will obviously go home and take the medicines. Okay. But he or she doesn't need to show anything to anybody.
Yeah.
But a surgeon, everybody can see our skills, what we are doing. Mm-hmm. Okay. So that is another attribute, which is probably something unique to the surgeons.
Right.
I hope I've answered that question, really, isn't it?
Oh, yeah.
So there are lots of attributes, okay, a surgeon or a doctor needs to have.
Mm-hmm. Besides those attributes and making sure that you have those, do you have any other advice for people considering the medical field, or even more specifically surgery, or even more specifically renal surgery and transplant surgery, or just any general advice for people?
I think what I would say is, apart from what I've said, I think I pretty much covered what somebody needs to have, but is listening and observing. Okay, listening very, very carefully, attentively, not passive listening. I mean active listening, not interrupting others, and listening to what others are saying, why they're saying. If they're saying something, let's say, for example, liver, it can bleed like hell. Why does it bleed? What is the reason for that, for example? And if you start asking questions like that and listening to the experts, okay, it will make you more knowledgeable. You will kind of respect. You'll understand better. Mm-hmm. And the second thing is questioning. It's really so important. Often, people don't ask questions because they're shy, or they don't want to be embarrassed by asking a question, or they think, oh, it's a naive question. Maybe you don't know what others think about it. Mm-hmm. Really, it doesn't really matter. There's nothing called naive questions. Okay, so that listening and questioning the kind of, why are you doing this in such a way? Why can't you do it differently? What is the reason for that? Okay, that will make you a much, much better doctor, because you're curious to know, and your brain is thinking all the time, and it is grasping that, taking that knowledge in, and then which you will use it for the treatment of the patients. I mean, I still remember what I did as a surgical trainee in India long time ago, and I thought, I don't know whether I'm going to use this or not. But when I became a consultant, lots of things I've learned 15 years ago actually came to use, because they're all stored in my somewhere in my subconsciously. Same thing with the medical school, the biochemistry, physiology we learn, the anatomy, all that kind of stuff is there, and then we apply that knowledge. And that happened purely because of the enthusiasm, the kind of the questioning I had in my mind all the time, and observing the experts how they do things. Okay.
Yeah. I don't have any other questions. Do you have
I think
anything?
I've talked a lot, isn't it?
I mean, yeah, but the information was super helpful. I learned a lot of information about.
Well, I do hope that you got an insight.
Uh-huh. Definitely, I have. Especially from someone with so much experience and training as you, it's incredible information to have.
Good. Well, I hope it was helpful, and you got what you wanted to get out of this interview. And let's hope that this kind of inspire younger generation like you and many other people, the students who wants to go into medicine.
Yeah.
It's fascinating. It's very, very satisfying, and it's really enjoyable. And I literally like to go to work every single day because I absolutely love what I do.
Mhm.
And it comes with time and obviously being patient and perseverant. um, you know but it's enjoyable, but it's also quite, I must say, can be quite exhaustive and tiring.
Right. Yeah. Well, thank you so much for all of your time. I really appreciated it, and I know for a fact everyone listening along also appreciated it. So thank you for your time.
No problem, Manish. Take care. Good luck. Okay, let me know
Thank
if
you.
you need anything. All right.
Yeah, absolutely, I will.
Okay, bye bye.
And a huge thank you to all of you listening along as well. I hope you learned something from Dr. Aroori, and be sure to tune in for the next episodes.